And I don't find it in most classes. There's a huge number of people like that. But for those that did, I'm sorry. So this is going to be talking about value and value in healthcare. And for me, the question I want to start with for consumers is value like beauty? Is beauty lies in the eyes of the beholder? I mean, we've heard this from Plato, we've heard this from lots of people. And the question is, for you as consumers, what is value? And that's what I want to talk about today. What is value from a consumer point of view? Now, I come from an economics background, and so I could give you an entire lecture on price. And I've testified in Congress 4 times on price and price transparency in healthcare and a variety of things. So we could talk about price if you want, but I wanted to talk about value today. And the question I've got for you is, what's important to you? When you think about the healthcare system, what does value mean to you? And so what I want to talk about it is from a variety of different perspectives, actually 5 perspectives. The first one is, what does it mean for you when you're a patient? What does value mean? When you're going and choosing a physician, what does value mean? When you're choosing a nursing home, what does value mean? When you're comparing hospitals one to another, what does value mean? And finally, and I do a lot of international comparisons, when you're comparing the U.S. healthcare system to the French or to the Japanese or to some other country, what does value mean? So I want to try to cover all 5 of those topics in my allotted 15 or so minutes. So, well, the first thing that you've got to recognize if you look at it is 100 years ago I would have been talking about infectious disease. 50 years ago I would have been talking about heart attacks. Now, if I look at where the burden of disease is in the United States, it's in chronic disease. And is the current system providing value to those people with chronic disease? They represent 90% of the utilization. They represent 90% of the expenditures. They have other issues, but they are the people that are responsible for most of the dollars and most of the visits in the United States. You would think, therefore, if it was any other business, that it would be oriented towards their needs, because they are the predominant utilizers of the service. And I'm just going to ask you if you think it is. So, I've got to define a chronic condition. Something that lasts a year or is expected to last a year or longer. It limits what we can do, and it requires ongoing care. And I've given this talk before, and somebody in the back of the room once said, Dr. Anderson, it's a reasonable definition of chronic disease. It's an equally good definition of marriage. So today, I don't know if we're talking about chronic disease or marriage here, but we're going to be talking about one of those two as we go through our discussion today. All right, so let's talk about a particular person, Mary Smith. She's 75 years old. She lives alone. She has a Social Security income and virtually nothing else. She has arthritis. She has high blood pressure. She has COPD. She has diabetes. And she has some difficulty walking and bathing. This is fairly typical of somebody who's 75 years old and utilizing the system. They are people with 3 or 5 chronic conditions and a functional limitation. So we've done some analysis of these people. If you use that as the definition, among adults 18 to 64, about 6.5% of the people fit into that category. If we're talking about people over the age of 65, almost 1/3 of the people fit into that category. So it's a big number of people that are very much like Mary Smith. What does Mary Smith want to do? Mary Smith does not necessarily think what I really need is a lot more health care. Okay? Not that health care is not good, but if you ask Mary Smith what she wants, it is typically not more health care. She wants to remain in her home. She wants to participate in society. And of course, she wants to maintain the best health care that she can. The question is the health care system that Mary Smith confronts anything like the health care system that she would like to have? And my answer in most cases is no. But you think of the Mary Smith that you know and ask, is the health care system doing well for her? And I think as consumer advocates, you really need to pay attention to how the health care system is not meeting a large number of her needs. What does the system provide? It provides uncoordinated medical care, generally fee-for-service care. It provides relatively few social services. And so the question in the broadest sense is Mary getting value from the current system? And my guess is, in most cases, Mary is not. The second part of it is all about caregiving. And the question is, when Mary Smith at 75 has a problem, she falls, something goes wrong in her living alone system, who's there? Typically, it's a family member. Typically, it's a daughter or a daughter-in-law that takes that responsibility. And when that happens, we lose a part of the productive workforce. And yet we don't have any system right now in the United States and to a large extent in most other industrialized countries that deal with this particular issue. And so the question is, what does Mary Smith need? And it's not what she's getting today. We heard about ACOs in the previous session. The United States is the land of opportunity. We try everything, and we are trying everything to take care of this population. We have accountable care organizations. We have care management programs. We have care transition programs. We have special needs plans. We have patient-centered medical homes. We have readmissions programs, which we talk about. And they're all designed to take care of the high-need population. We then evaluated them. And I've been doing these evaluations for a long time. We start with the peer-reviewed literature. That's, as academics, that's where we go. We want to have where somebody has written an academic paper and said, oh, we had a positive result. In the ACO, we reduced the number of readmissions. We did something good. Now, there's a clear publication bias in anything that we do because we want to show a positive result, and if it's a negative result, the journal probably won't publish it. So you've got to understand there is a huge bias. We then look for programs in the peer-reviewed literature all over the world for success. There were not very many of them. There were almost none. Very few examples of success in the peer-reviewed literature. We also went to CMS, and we went to Blue Cross, and we went to a variety of things. And we saw some more examples, but they weren't in the peer-reviewed literature, and they had a different methodology in most cases. So we were concerned about that. So we decided to focus primarily on the peer-reviewed literature. But we did find some, and we continue to find some as we go through the process. What was more amazing to me than the fact that we didn't find a lot was we then went back and re-interviewed them and asked them, are you still around? These are papers, these are programs that were in the peer-reviewed literature. Only half of them remained. Why? mostly because they didn't have the economics rights. It wasn't that they weren't improving quality. It wasn't they were improving satisfaction, which are two of the three aims. It was they didn't have the economics right. And so if you don't have the economics right, it just is not a sustainable program. And so that's sort of what we learned from that activity. We also learned that most of these programs have only partial success. They work in one setting, but they don't work very well in another setting. I was just on a National Academy of Medicine program, and we looked at programs, and some of them were very good at end-of-life care, but didn't do anything else. Some of them were very good with children, but didn't do anything else. Some of them were good with the frail elderly, but couldn't handle any of the other populations. So they're very much niche population that they're able to take care of as well. So for example, at Johns Hopkins, we had a program called Guided Care, which was a care management program. It did not really work at Johns Hopkins. It worked reasonably well at Kaiser Permanente. Why? At Johns Hopkins, we have 1,600 physicians who really don't know each other. At Kaiser Permanente, they work together all of the time. And they do know each other, and they work together, and they have information systems that work better and whatever. So what a program that works in one setting doesn't always work well in another setting. But here's something that you probably know, but I think is always worth repeating. We in the United States are the most expensive in healthcare of all the countries. You all know that. We are the least expensive in social services among all the industrialized countries. We do not invest in social care. And what does Mary need? She really needs social care. She doesn't need medical care. And as we have moved the system for ACOs and everything else, we have moved it towards more medical care. We have put the medical care system in charge of the healthcare, of the social service system. Readmissions want to be reduced because we reduced healthcare expenditures. And the reason why we're going to invest in social services is because it'll reduce medical spending, not because it's a good thing. It's because it'll reduce medical spending. So we have essentially chosen a system that is very healthcare oriented. We are exacerbating that problem with most of the programs that we have developed, and so we're essentially doing this. People with 5 or more chronic conditions see an average of 13 different physicians during the year. How do they know which doctor do they like? What information is available to assist them? I'm not going to talk about can you find out if how much the doctor costs, because that's almost impossible. But what information do we have available? What does CMS and other things tell us is available? Well, essentially, these are 5 of the indicators that are available to you. 30-day all-cause, risk standardized, readmission rates following a heart failure hospitalization. And you can read the other 5. Is that how you choose your cardiologist? Is that the information you want the consumer to have? That's the information that the medical care system is giving you. Do you want that information? Sometime we might have to choose a nursing home. What information do we have? We can tell you the percentage of the residents experiencing 1 or more falls with a major injury. I'm sure that's important information to have. But is that how you're going to choose your nursing home, based upon that information? That's what the medical care system is giving the consumers to make a choice. How do you measure value in a hospital? Johns Hopkins has been talking about we're number 1, we're number 2, we're number 3. Penn is talking about we're number 3, 2, whatever, for a long time. Let me just read this to you. It's a paper that came out in Health Affairs about 2015. attempts to measure the quality and safety of hospitals have proliferated, and including a growing number of consumer-directed hospital rating systems. However, relatively little is known about how what these rating systems reveal. To better understand differences in hospital ratings, we compared 4 national rating systems. We designated high and low performers in each system and examined the overlap among the rating systems and the hospital characteristics corresponding with performance on each. No hospital was rated as a high performer on all 4 rating systems. Only 10% of the 844 hospitals rated as high performers by one rating system were rated by high performer by any of the other rating systems. The lack of agreement among the hospital rating systems is likely to be explained by the fact that each hospital uses its own rating methods, has a different focus to its ratings, and it stresses different measures of performance. So the question is, what is the value measure that you essentially want to use as a hospital? As I said, I do a lot of international comparisons. What do you care about internationally? You know, we all can say the United States is too expensive and poorly organized. But what do we mean? What is the attributes that makes value there? So I'm going to just ask you a series of questions about your values. I'm not going to ask you to raise your hand and tell me what your values are, but I'd like you to think about what your values are. First question, is healthcare a right? You can all say yes, but in the United States, it's clearly not a right. Only the countries in green have universal coverage, so it's not essentially a right. International aid. If you go to most low and middle income countries, half of the revenues to fund the programs, the health programs, come from international aid agencies. Whose preferences should dominate? Should it be the country, or should it be the Gates Foundation and the World Bank and USAID? Who's in control here? Let's assume the International Aid Agency wants to fund AIDS. Let's assume that the country really cares about diabetes. Whose preferences? United States, they pay less because we have a premium system. Premiums is a flat amount. You pay $20,000, $10,000, whatever you pay for your insurance package. If you're a $100,000 earner, it's 10%. If you're a $200,000 earner, it's 5%. So it's a regressive way to finance. Do we want to do that? Depending on your values. Pooling. Who's in our pool? We talked earlier about, having everybody in Philadelphia be part of the system, or not. Who's in our pool? The Affordable Care Act debate is all about pooling. The rich pay higher taxes in the Medicare, in the system to fund a part of the program for the poor. On average, the younger people are healthier than the poorer people, and than the older people. Question is, how many categories do you have? We know that 20% of us use 80% of the expenditures and 80% of us use 20%. Who do you want in your pool? And, if we have minority groups, if we have inner city groups, they often tend to be sicker. Who do we want? That's what the ACA fight is about, although we don't really talk about it in that way. In delivery, is it a public system? Is it a private system? Or as we have it, a little bit of both? Do we want to emphasize equality? Or do we want to emphasize equity? We haven't decided that. Often we say equality. But as the chart says, quality's not going to get you there. That little kid can't see. It's a big difference in this activity. Payment systems. What do we emphasize? Do we emphasize cost containment, access, quality of care? Which of these values do we want? Depending on which one, we're going to get more or fewer services. We're going to get better or worse access. We're going to get better or worse quality depending on how we decide to pay for things. We've got to get the consumer involved. Cost sharing. If I give this talk in Europe, They say, why would you ask anybody to pay anything when they go to the doctor? It's free. You shouldn't have cost effect. You shouldn't have cost to determining it. We in the United States have lots of cost sharing. That's a value system. That's a value choice. As consumers, do you want to have to pay when you go to the doctor? How much do you want to pay? Increasingly, we're paying more and more. High deductible health plans, all these things. Do we want to do those things? Can consumers make informed decisions? What information do we want to have to make a better decision? We can't know as much as a doctor. Well, probably never. But the information I showed you about doctors and nursing homes, and I didn't show you, but I could have shown you the same information about hospitals. Is that an important thing to know? Or as a consumer, do you want to know something else? And if it is, you need to start talking to people about those kinds of things. So lots of things determine our values. I can't give you what your values are, but as consumers, you've got to essentially do it. There isn't any optimal system. I mean, I tend to like certain systems, but that's my preferences, and it wouldn't necessarily be your preferences. But the key message that I have for you today is, really, are your values being reflected in the information that we're giving you as consumers? And my guess is no. You're not getting the information that you need to make an informed decision. And so the question is, what do you want to know? What do you want to know? Thank you.